Good afternoon. Welcome back to EMS Grand Rounds. This is part 2 of our series on post-ROSC care. What do you do with the patient when you actually get them back? What did we talk about last time regarding post-ROSC care? Well, number one, we said this is the time when things get kind of hairy because most of us have a great plan for what we're going to do when we're resuscitating somebody. As soon as that resuscitation ends, then the actual resuscitation of the patient starts and not just the cardiac arrest management. And that can be a little tricky to do because that requires the best care that we can possibly give, because these are some of the sickest people that you're going to see, and certainly the sickest people that you're going to see that are alive. So, thing number one is don't let this become a goat rodeo. Have a plan, know what you're going to do, be thinking about what am I going to do when I get pulses back, when you're actually doing the resuscitation itself, so that you're ready for this stuff when it comes up. So number one, have a plan for it. Number two, again, we're going to make these people think that they're on some sort of sandy beach somewhere instead of having just gotten their chest pounded on for 30 minutes by a bunch of burly firefighters. So the whole goal is to make them not realize that they are newly back from the dead and think that they're on vacation someplace. We're going to do that through good control of their airway, good control of their ventilation, their respiration, and their hemodynamics, and good sedation. So we are going to need to control these people's airway in cardiac arrest. We often say, it doesn't really matter that much. You can bag them, you can put in an eye-gel, you can intubate them, whatever you feel like. Maybe there's some benefit to some of them, but that's outside what I'm going to talk about right now. Nonetheless, now it actually does make a difference. So we are going to probably need to intubate most of these people or put in some sort of blind insertion airway device or a supraglottic device. If we're going to do that, we've got to be very careful because these people are very fragile, so we need to work on patient positioning. We need to have good pre-oxygenation. We need to not rush this because now we've got a little bit of time to do it right, and we can't just be grabbing their jaw and throwing a tube in there, all hell or high water sort of thing. And we should do this with great technique, have an experienced intubator doing it, and use apneic oxygenation. How do you do that? Whenever you're going to intubate somebody, especially a living person, put the nasal cannula on them, a real nasal cannula, not the end-tidal CO2 thing. Put a real nasal cannula on them, crank it up past 15 liters, as high as basically the knob will go, and let it blow in their face. Again, this won't really work to oxygenate a living person who has airway reflexes and can reject all the oxygen blowing in there. This will work very well in the unconscious person who doesn't have airway reflexes or real significant respirations otherwise. We're going to want to maintain their ventilation, and ventilation is super important, as is oxygenation, but ventilation we are going to shoot using set tidal volume and variable rate of breathing. We are going to aim for 35 to 45 millimeters of mercury after the patient kind of settles out a little bit. See my vent talk to know a little bit more about what we're doing there, but aim between 35 and 45 millimeters of mercury on our end-tidal CO2, which should be on the end of every tube every time. And then we're going to aim for an oxygenation not of 100%, but of somewhere between 94 and 99%. If it's higher than 99%, we're going to decrease the amount of oxygen that we're providing. If it's lower than 94, we're going to do some stuff to assist with that as well. The easiest way to, of course, get your oxygenation and ventilation standardized is to use a ventilator. If you don't have access to a ventilator, then you probably should get access to some sort of simple ventilator, and it doesn't have to be a super expensive, Hamilton T1 or anything like that. The pneumatic powered ventilators will work just fine for our basic needs here. And we're going to establish some reasonable vent parameters, starting with a set safe tidal volume that we're really not going to mess with. We're going to set a safe respiratory rate, good PEEP, and use our PEEP as our primary means of oxygenation, and then start at 100% FiO2 and decrease our FiO2 until we're able to maintain a SAT between 94 and 99%. We're going to maintain the patient's sedation because these people can get quite rowdy. Often they don't, but everybody who's starting to move around probably deserves at least a little slug of ketamine. You can give that IV. Or IM. IV is probably a little bit more preferred in the pre-hospital setting for these folks because it will wear off relatively quickly. But at a dose of 1 to 2 milligrams per kilogram in a bolus, it will bring most people down and make them comfortable while you're doing all the other stuff you need to have happen after you get ROSC with them. Now, if the patient is awake and talking, great. Most of these patients won't be, though. And so there's no reason to let them kind of flail around just for the sake of letting them flail around because you're worried about sedating them. Go ahead and give them some sedating medicine in order so that you can get the rest of your stuff done, because honestly their mental status doesn't matter all that much for about the next 30 minutes or so, at least in terms of what their neuro exam is like. We can deal with that later. Go ahead and keep them down now. That's my opinion, by the way. Not everybody agrees, but that's pretty good opinion if you ask me. And then we're going to maintain their hemodynamics. We're going to aim for a MAP of 65 to 70 or a systolic greater than 90, probably MAP's more important. We're going to do that through a combination of drugs and fluid administration. Be cautious that most of these folks may have some degree of heart failure or at least a newly failed heart, so slamming in 6 liters of IV fluid is probably not the best idea. It's going to take some sort of drug administration. If you know that they're in cardiogenic shock because somebody at another hospital where you're moving the patient from has done an echo, or you've done it yourself in the back of the ambulance, and you see a little quivering heart like this, something with strict inotropy like dobutamine may be a good choice if you have that available. In absence of that, most folks will do real well with straight up Levophed, which has become our first line pressor for pretty much everything. For most EMS services, if you have Levophed available, great, and a lot of air services do, but if you don't, then what you can use is a little bit of epinephrine. They don't have to go on a drip. Push dose epi will work really well for most of our shorter transports, 15, 20 minutes, something like that. Rather than setting up a drip, you can make up some push dose epinephrine and give it every 3 to 5 minutes or so. And how do you actually do that? The shortcut, again, we can talk about how to do it more in depth at some other point, but the easiest way in my mind is to take a 10 ml Carpuject of epinephrine, the same stuff that you would have given during the code, the 1 milligram per 10 mLs, squirt that into a 100 ml bag of saline, and then give it a good shake, and then draw out 10 mLs of saline epinephrine combination at a time. That will give you a syringe with a concentration of 10 micrograms per milliliter, and then you can give 1 to 2 mLs of that every 3 to 5 minutes as the patient's blood pressure needs in order to keep them with a MAP of 65 or above, or a systolic of greater than 90, depending on what parameter you're using. One more time, whole thing of resuscitation epinephrine, not the multi-dose, but the regular old stuff you would have just given when he was in cardiac arrest. Squirt that into a 100 ml bag, shake it up, 10 ml syringe of that, and give 1 to 2 mLs every 3 to 5 minutes as needed. Great. That's all the stuff about how to sort of get the patient to the hospital. We're going to mitigate the life threats, as I kind of mentioned before. And we do have to watch that because a lot of these folks will rearrest shortly if we're not paying close attention to it. Some of them will sail on forever without a whole lot of support, but many of them will need some sort of immediate life threat management. The folks that we are able to get through here, though, are going to run into this thing that we call the post-arrest syndrome, and that's the next little bit that we'll hit on here. So, again, when someone goes into cardiac arrest, it's not just that they generally had an arrest, and then if you get them back, everything's hunky-dory, they wake up and they start talking to you again. That's the stuff of fiction, for the most part. Not everybody, but for the most part, most people we see are going to have some degree of post-cardiac arrest dysfunction afterwards. And this is probably a combination of metabolic dysfunction, of global anoxia and hypoxia, and then after you restore blood flow to all these tissues that have been ischemic for a while, they're not quite sure what to do with it, and you get some free radicals generated, and you get calcium and potassium kind of jumping all over the place, and things crossing membranes, and cell layers falling apart, and all this kind of stuff that acts almost like a sepsis kind of syndrome in and of itself. And over the next couple of days, you can pretty predictably find this person will have another crash again when this thing really kind of kicks in. It's essentially an entire body post-ischemia inflammatory state, and it manifests with cardiac dysfunction and hemodynamic instability and vascular collapse and ARDS and all the terrible stuff that basically anybody who just died you'll see generate again. So we want to do some stuff to mitigate that post-cardiac arrest syndrome. One of the things that we've found that actually helps with this, and there's not many of them, you may have seen, is cooling. What about therapeutic hypothermia? That was the thing. When I was a medical student coming up through residency and into fellowship, this was the thing. And by the time I graduated fellowship, the year before that, I distinctly remember hearing, if you don't cool somebody pre-hospital after their cardiac arrest, especially their shockable cardiac arrest, you are not meeting the standard of care. What's that based on? A couple of studies back from around now the turn of the century. Basically, 2 big trials came out that showed that folks who got chilled, their temperature taken down to 32, 33 degrees after their cardiac arrest, folks who were able to get down to that temperature did better after their cardiac arrest than folks who did not. who we didn't provide that therapeutic hypothermia, that therapeutic cooling. And again, 2 big trials that did this, and it was pretty striking results. The the percentage of people almost doubled who had a good neurologic outcome. So it wasn't just that we created a bunch more folks who would then go on to nursing homes and live on vents for the rest of their lives and got trached and pegged and it ended up in a way that nobody really wants to be. These were folks that actually walked out of the hospital and went on to pay taxes and cook their own dinner and that sort of thing. So this was pretty good and a pretty big deal. However, right as I was kind of getting out of my official training, a couple more papers came out that totally kind of blew that back on its heels, and that was the beginning of why we don't really do a lot of pre-hospital cooling anymore, or a lot of ED cooling for that matter. One of them was this, and this was basically a study of if we get people cold with 2 liters of ice cold saline after their cardiac arrest, what happens to them, and this was a pre-hospital study. What we unfortunately found was that these curves basically overlap each other. So the folks that got cooled versus the folks that did not had the same survival over the same length of time. We didn't really generate a whole lot more survivors. And by the way, this is pre-hospital cooling. This is if you got 2 liters of saline and got your temperature down in the field versus folks who would have gotten cooled probably in the hospital. The folks in the field also had a higher rate of rearrest and more pulmonary edema. So not only did it not seem to help versus the folks that waited until the hospital to potentially get cooled, it seemed to cause them to rearrest more and have more pulmonary edema. So right about that same time period, there was another study that came out, and it may have even been the same meeting, if I remember correctly. But the question on this paper was, what happens if we take people down to just 36 degrees Celsius instead of 33 degrees Celsius? Now, for reference, if you don't work in Celsius, 36 degrees is just slightly cooler than body temperature. Like if body temperature is about 37, so we just go down to 36, ever so slightly cooler, versus 33, which is fairly significant mild hypothermia. What happens to those folks who get taken way down to the actual hypothermia stage versus just slightly cooler than body temperature? And what we found here was that, again, the survival curves overlap. So no real difference in terms of whether or not you took somebody to 36 degrees for 24 hours and kept them there, or if you got them all the way down to 33 degrees and kept them there. No real difference in survival or neurological outcomes, which really, again, throws everything back because everybody in the United States that had a shockable rhythm that made it to the hospital was going to get really cold for the next 24 hours and all the attendant problems that can come along with it, because it's not super easy to bring somebody back from that when you start warming them up. Nonetheless, the survival curves are the same. No benefit to taking somebody to 33 degrees. Now, one of the things we think might have happened was that if you look at the original data and you look at everybody's temperatures, you find that the folks that got hypothermia, therapeutic hypothermia, down to 33 degrees for 24 hours and then stayed there and were rewarmed, these are the guys that did better. However, the folks that did not get hypothermia, not only did they get a temperature of 36 degrees and kind of stay there, they actually got a fever. So starting at about 8 hours in, these folks' temperature went up, and most of them, the average temperature was in the febrile range. And that also plays out for the targeted temperature management 33. Again, you bring the temperature down and they stay there. These guys, however, that were targeted to 36 did not get that fever. So it doesn't seem to matter whether or not you fall in the green line because your temperature stayed at about 36 degrees, or if you fall in either of the blue lines because you went down to 33 degrees. The big thing seems to be, as long as you didn't track along the red line, as long as you didn't get a fever after your cardiac arrest, that seemed to be the thing that, or at least we hypothesized, that's the thing that led to better outcomes. Folks subsequently, after the publication of these couple of papers, the 2 papers that showed that there probably wasn't a benefit to pre-hospital cooling and probably wasn't a benefit to taking somebody down to 33 degrees, folks immediately went to think, oh, okay, that means keeping somebody cool is probably bad, so don't do that. You're going to hurt these people if you bring their temperature down real fast. We shouldn't cool anybody. And that's really not what the study said. Again, the survival curves are basically the same. So whether or not they got pre-hospital cooling or whether they didn't, survival was about the same. Whether or not they got cooled to 33 or 36, survival was the same. And both of those are better than doing nothing. all this basically showed was that we probably don't have to get them cold with 2 liters of ice cold saline in the field, and then we probably don't have to get them down to 33 degrees all the time. There's probably benefit to just not letting them get a fever. So that is not to say if somebody ever comes up and says, oh, you shouldn't be doing that pre-hospital cooling stuff. Again, the overall survival is about the same. So it becomes still better than not doing anything if that comes up. Now, again, this may be a systems level issue, and this may be something that is above your pay grade as a working paramedic on the street or a working flight nurse or flight paramedic in an aircraft. But just now you kind of know the background of it. It's not so much that we think that cooling is bad. It's that maybe we don't have to get them as cool or as fast as we thought we once did. So fever is bad. Cool, still good. Now, I've been asked the question before, what if the patient is already cold? Say I pulled him out of a lake, he was a cardiac arrest, we got him warmed up to 88, now we got ROSC. Do I continue to warm him up? Do I leave him down there? Cold is good, is better cold, more good? Do I actively try to warm him up? Am I going to cause him trouble if I do that? The short answer is that we should maintain most people between 32 and 36. And if you remember nothing else, just remember your post-ROSC patient should probably be between 32 and 36 degrees ideally. That's the state when he is maybe not going to think that he's laying on a sandy beach someplace because it's going to be too warm for that, but where he thinks he's in his bed at home kind of snuggled up. So just a little bit cooler than normal is what you really want. Below 32 degrees, you run the risk of ventricular dysrhythmia and cardiac dysrhythmia whenever you have these folks. So it's better to get them warmed up to at least 32 degrees, if not up to 36. Now, in your post-cardiac arrest patients, you may not have to go a lot higher than 32. The enemy of good is perfect. So trying to get everybody up to 36 degrees maybe is not necessary, but at least get your primary hypothermia patients up to 32 to get them out of the woods for things like malignant arrhythmias and that sort of stuff. The other question is, who should we work on cooling? Well, again, this probably doesn't matter for most of us in the EMS setting, but kind of be aware that there's really no patient that targeted temperature management is contraindicated, meaning that we shouldn't prevent them from getting a fever. And if that means keeping them somewhere between 32 and 36, that's probably pretty good. Now, we've talked about mitigating the post-arrest syndrome, which basically all we have right now, pending other studies, is targeted temperature management. And even then, most places will have that kind of laid out just for the initial shockable rhythm patients, the VFVT patients. The next thing we're going to do, after we try to mitigate as much of the post-cardiac arrest syndrome as we can, is start treating the cause. And we're going to talk about that in just a minute. So.